Hello and welcome to the Hardy Brain, the show that takes athletic, introverted entrepreneurs and leaders and transforms them into ironclad brain performers. I'm your host, Dr. David Hardy, and we've got another amazing guest on our show. He's a psychologist, a neuroscientist, and an fMRI specialist at Perceptive and Imperial College London, doing amazing research in all sorts of fields from psychedelics to hormones to sex differences in the brain. And this is going to be exciting. So welcome to the show, Matthew Wall. How are you doing today?
Yeah, good. Thanks. Thanks for inviting me.
Absolutely. Now, a lot of people out there are taking a lot of different substances, and you're looking at what's that doing to the brain, and is it good? Is it bad? What's kind of your overall perspective on what people are doing to themselves, or how can we get them better?
Well, it's a big question. So, I mean, a lot of drug taking is not good, let's say. But there's been a bit of a shift in the last 10, 20 years around particular things. I'm thinking about medical cannabis. Which, I guess the US started kind of legalizing around 20 years ago. And I'm thinking particularly about psychedelic drugs. So, both cannabis and psychedelics have, traditionally, if you like, been seen as drugs that people use recreationally and drugs of abuse. But particularly with cannabis now, there's lots of medical uses being recognized. And more recently, psychedelic drugs have started to generate quite a bit of interest in terms of how they can be used to treat depression, anxiety, eating disorders, various other kinds of things, post-traumatic stress disorder. And there's currently a lot of interest in those things, both kind of scientifically and in the commercial area.
Right.
There's lots of companies started up in the last few years.
Well, let's start off with the lower drug, and then we'll get to the harder drugs in a bit here. Sure. But one thing I've always been curious about is, we're starting to get more and more research, and things are tossed in the medical realm. But two, what's the difference between kind of a responsible use versus, say, that party use and maybe chronic use, all of these? What's kind of been your thought process on this from, okay, well, no, this is an addiction now, or this is something that's going to help somebody out and improve their lives?
With cannabis, cannabis has actually really changed in the last 20 to 30 years. So cannabis, I'm talking about cannabis on the kind of illegal market now, if you like.
Right.
Which is what we still, the only real cannabis that we have now in the UK it is technically legally medical, but people have a hard time getting access to it. So cannabis 30 years ago was maybe 3 or 4% THC, which is the active ingredient in cannabis, tetrahydrocannabinol. And nowadays you're getting strains of cannabis that have been selectively bred to maximize their THC content, and you're getting up to 35-40% THC in the most extreme cases. So the drug itself has changed quite significantly. And 30 years ago, you really didn't get people reporting problematic cannabis use. Nobody ever went to a drug clinic and said, "I'm addicted to cannabis, please help me."
Right.
Nowadays, that's relatively common. And there are other issues like cannabis-induced psychosis that we're starting to see. So really the drug itself has changed. And there are complicated reasons for that about, the supply and demand and things. And we're starting to see changes in the problems that people are having with it as a result. Now, it's a difficult line to draw between recreational usage and people who are using it for valid medical reasons. And there's a big grey area there in the middle. But it's sometimes difficult to say whether somebody's usage is really going to be problematic or not.
Right. Now, on the medical side, though, and uses, what would it benefit people with? So if someone was to prescribe it or to be prescribed,
Yeah.
what areas do you think it does have benefits?
So, I mean, people have found it very useful in glaucoma because it reduces the pressure inside the eyes. Probably the most common usage is pain, chronic pain.
Right.
Of various kinds, kind of low back pain or fibromyalgia or various other chronic pain conditions. That tends to be what people use it for.
Yeah. Now, is this just going to be a substance that kind of just masks things, or is it actually changing the brain structure so that the pain is an actual good, a proper kind of response to what's happening to a person?
That's an interesting question. I don't think we have a very good answer. So the work that we've been doing with cannabis at Imperial College London and at University College London, we've been looking at people's brains while they've, just after they've had a dose of cannabis, and we found that it reduces activity in a particular brain network called the salience network,
right?
Which is a network of brain areas, and some of those areas overlap quite a lot with the areas of the brain that are responding to pain. So possibly what's happening is that the cannabis is reducing activity in that network, and that's what's giving some of the pain relief. But it's a relatively short-term effect. So we've also looked at people who have been chronic users for a long time, trying to identify kind of longer-term brain changes. And the brain changes are relatively subtle. So you can't pick up, you can pick up a few little changes in function, but the brain changes don't seem to be very, very profound. So it's probably more likely just a kind of an acute effect while they're, using the drug, and then it wears off, if you like.
Now, on that note, though, like Dr. Amen studies kind of pop up because, he's out there in the media a little more, and the scans he's been showing and kind of his conclusions, and people can look it up, that I've gathered is that it's going to slow down different parts of the brain, and long-term use is not a healthy thing for people. But you're saying it's more of a subtle one?
Well, I mean, there are lots of different ways that people use these things.
Yeah.
I mean, chronic use for a long time with high doses of anything is not a good idea, for sure.
Right. Okay. Now, what about its effects on memory, and not just with THC, but non-THC products? And the reason I bring this up was I did actually try one product that was non-THC based, and I felt like I had less pain, whether it was my knee or whatever else. But during that day, I felt dumb. Like I was forgetting things that I should be able to recall easily. Okay. And this was like a pretty benign product. So what is kind of the research on memory with this as well? Because everyone knows that one person who tokes up too much and and doesn't remember much.
Sure. So, I mean, I think there's really not a huge amount of work showing really bad long term effects. So yeah, you get acute effects for sure. So when you're stoned, your attention is all over the place and your memory is all over the place. And there are what we've identified is there are lots of different brain networks that it affects. And it generally has the effect of reducing activity in these different brain networks, which makes sense. It's not a stimulant. It's a kind of a depressant almost. It
Right.
doesn't make you want to go out and run a marathon. It makes you want to sit on the couch and eat chips, right?
Yeah.
So, but the most of the long term studies, and it's always difficult when you're doing these studies because you're wanting to identify a group of cannabis users and then a group of non-cannabis users, right? But those two groups are probably going to differ in a lot of ways, other
Oh,
than
yes.
just their cannabis usage.
Yeah.
Level of education, socioeconomic status, whatever. So
Well, on that point, what about identifying different groups that are maybe predisposed to wanting one substance over the others? Because I know you do some addiction work as well. Uh, what have you seen kind of in brain structures that would maybe predispose somebody to say, "Oh, yeah, I need that next toke or whatever else," or "No, that's just not my thing. I like this party thing better," or whatever else.
well, that's a great question. um I think it comes back to the a really difficult issue in the kind of work that I do, which is about trying to identify valid biomarkers in general.
Right.
So people have been looking into this for a long time. People have been talking about imaging based biomarkers for 20 years. And this is going to be a long roundabout explanation, but I'll come back to the point eventually, I promise. Um, so, ideally, what we'd like is to be able to scan somebody's brain and identify some aspect of brain structure or function which explains whatever problems they might be having, whether that's depression or anxiety or
Right.
eating disorders or whatever. In the same way that, if you go to your doctor and your doctor does a particular blood test and looks for a particular protein marker in your blood, if that protein is in your blood, your doctor will know that you have cancer, and he might even know that it's a particular type of cancer. Okay, and it's completely accurate and completely diagnostic. It's a bit dark, sorry, a bit of a dark example, but it's
It's an
it's
example.
a clear one.
Absolutely.
So it's completely clear, it's completely diagnostic. So what we like is a version of that for psychiatric disorders, depression,
Right.
anxiety, post-traumatic stress disorder, whatever. And so far, we've been fairly unsuccessful at finding anything like that. We can't look at a brain scan and see a broken piece of brain in there and go, oh yeah, that's the problem.
Right. A
Now, what
lot
you can,
more subtle and a lot more functional, and
well,
there's so many different
this is
factors,
the
right?
thing. We don't really know. We don't know if we're looking in the right ways. We don't know if we're looking at the right features. There are hints. What you can do is you can take a group of depressed patients and a group of healthy controls and compare their brains in lots of different sophisticated ways, and you can find differences. Kind of on average, you can say, okay, the depressed subjects have 10% less activity in their hippocampus than the control subjects.
Mm, right.
But what you always find is that the distributions of those things really overlap to a large extent. So you're looking at a relatively small difference between these groups, and any one individual that you pick out of those groups is going to be somewhere in the middle in the overlapping bit between the two groups, if you like.
Right.
So the problem is really moving from these group level effects that we can identify that are giving us some hints, and really refining that and being able to apply these things to an individual subject. So coming back to your original question, can we look at somebody's brain and see which drugs they prefer? Well, at the moment, no.
No.
But
It's a very, very complex system. And two,
sure.
Correct me if I'm wrong, but one of the limitations, especially of imaging, is that it's not a dynamic thing. You're looking at more resting state potentials. And when somebody's lying down in the machine, you can maybe give them a cue or maybe a cognitive thing at the same time, but they're not moving. They're not having to do a whole bunch of things that puts stress on the brain or activates other areas at the same time. Correct?
Sure.
Or,
Yeah. I mean, it's a very artificial environment. You're lying, when we're doing my MRI studies, you're lying in a little metal tube, listening to horrible noises that the machine makes. And maybe we're flashing some pictures of drugs at you and asking you, how much you're craving drugs right now. And you're like, well, I'm in a tiny metal coffin and somebody's banging it with hammers. I don't, it's completely artificial environment. But it's the best we can do. So yeah, you're right. That's another big issue. The kind of ecological validity of this stuff is perhaps not great. Though there are people working on portable helmet brain scanners with different kinds of technology and things that people can wear.
Wow. Yeah,
that's cool.
That will be something when those come out as well. And but with those limitations, what kind of findings have you found in some of your different studies that have just like floored you or being like, well, we're onto something here?
Well, I mean, we're interested in what effect drugs have on the brain, basically. And that is, of course, context is important for these things. So, when people might take psychedelic drugs at a music festival, for instance, the context in which they do that is quite important in the kind of experience they have. But you can still get, even with the, lying in a small metal coffin, you can still get a pretty good idea of what the kind of pure effect of the drug is on the brain.
Right.
And so, for instance, with the psychedelic drug studies that we've been doing recently, what you find is that psychedelics, in some ways, have kind of the opposite effect to cannabis on the brain, in that the general effect is kind of stimulatory, but they have this effect. So I'm talking about drugs like LSD, psilocybin, which you get from magic mushrooms, and other kind of hallucinogenic drugs. The general effect is that it destabilizes the normal brain networks, the normal pattern of functioning of the brain. The brain's wired up into these networks that communicate with each other and between the networks. And what you find is that psychedelics tend to destabilize that whole system. So you get much more random connections in the brain. You get areas that normally talk to each other quite a lot not talking to each other, and you get areas that don't talk to each other very much talking to each other. So it flattens the whole system. And that's given us some important insights about how we might use these things in therapy. So the current theories about how psychedelics can help people in a therapy situation are based on this idea that it has this effect on the brain where it shakes up a snow globe, and all the little pieces of snow fly up into the air, and then they all settle again in a different pattern.
Okay.
And
So
it
yeah,
gives you
pattern disruption.
right. It gives you
Wow, that's a great analogy. I like that.
a window of time where the brain is in a very flexible plastic state.
Yes.
And if you use that window, and if you do the right therapy tailored to whatever the disorder is that your patient has, then you can get them out of the ruts that they're in with their particular problem, whether it's depression or addiction or something else, and you can
Well, this is
allow
this
new
is
patterns to
fascinating.
form.
So, yeah, and this is why it grabs me. You said right therapy, and I picked up on all the work you're doing with different networks in the brain as well, looking at them, and then this area and time period you mentioned of things being more plastic.
Mm.
So, with that being stated, and especially with you saying choosing the right therapies to do,
Mm.
and going back to those guitars in the back of your background, the music, a lot of the brain is sensory processing.
Mm-hmm.
So to rewire these different networks, what's kind of your feel then on neuro rehab targeting these different networks with sensory stimulation? And then maybe a combination of a psychedelic. Do you see it as being like a 1 + 1 = 3,000, or where kind of
I
is your
mean, I mean,
optimism on
I mean,
things like that?
maybe. I mean, I think we are just at the start of what we're going to be able to use psychedelics for. And there are people talking about psychedelic therapy for people with traumatic brain injury,
Hmm.
and for stroke patients. I mean, people that have had injuries to their brain, basically, because they do seem to have this effect on neuroplasticity. They do seem to be able to open up critical periods as well. So there's a lot of work done with these things in animals. Not my work, but a lot of work showing that the rats and mice learning to run through mazes. Okay, young rats and mice will learn a maze very quickly. Older rats and mice will take a bit longer to do it. Okay,
Right.
like learning a language is, it's easy when you're a kid. When you're an adult, it's a lot harder.
Much, much harder.
Yeah. So there's this idea that there's critical periods for learning things, and if you don't learn another language when you're a kid, that's it. Bad luck. The critical period's over. The window's closed, and you have to try a lot harder. What happens though if you give a dose of psychedelics to these older rats is that you find they learn a new maze just as quick as the young ones.
Wow.
So there's this idea that psychedelics might be able to reopen critical periods for learning stuff as well. And if we can harness that for things like neuro rehab, post stroke rehab, traumatic brain injury patients, where they have to basically, what you're trying to do with those rehab things is you're trying to get the brain to root around the damage, if you like,
Right.
and trying to develop other areas of the brain to take over some of the functions of the bits that have been damaged. So if psychedelics can possibly help accelerate that, I think that's really worth investigating. I don't know if anybody's looking. I've certainly heard chatter about that kind of thing.
Okay.
I don't know if
Now, on that
anybody's
point,
actually
though,
looking into
have
that.
you, like with a lot of neuro rehab,
Mm,
sometimes, well, most of the time, the patients are more fragile. Things have, as you said, either been destroyed and need to be form new actual tissue, and then other times it's just kind of scrambled up. But with all of those, it's a fragile brain, and
mm,
fatigability is an issue. Have
sure.
you found in any of these studies, or could you maybe see it that yeah, maybe a dosage would be too much for somebody and overexcite them and make them worse, or
I mean, possibly, yeah. I mean, with these patient groups, you'd have to take these things, take it very cautiously, I would think. Yeah, I mean, these psychedelic
what about
drugs.
even in normal studies? Have you noted a point where things just changed more dramatically with a higher, different dosage?
Um, Somewhat. I mean, you do have to be really careful using these drugs for sure. Um, these are very sharp blades, right? You can do a lot of good with medicine in medicine with a sharp blade, but you can do a lot of damage as well. Um, there's a good example. So at Imperial College, we've done a few studies with depression and a couple of other disorders, and we've been using relatively high doses of psilocybin in those. So for the depression studies, we used 25 milligrams, and that's enough to give most people a quite intense experience. And then the my colleagues at Imperial College were setting up another study where they were looking at obsessive compulsive disorder patients, and as part of that, the planning process, really, they did a consultation with a bunch of obsessive compulsive disorder patients. This is what we're planning to do. This is always a good thing to do when you're designing these studies: get the patients involved and see what they think.
Oh,
So this is
absolutely.
what we're planning to do, and so on. Get feedback and refine your design. So as part of that process, they actually decided to go with a much lower dosage for these OCD patients. So they went with 10 milligrams because the feedback they got was, we don't like feeling out of control. We
Uh,
think you know we think we're really going to struggle if we're not feeling in control at all times. Um, so as a result of that, they reduced the dose down to 10 milligrams for those patients, and they're still seeing some pretty good results from that trial.
and that kind of goes in the debate too about microdosing. And obviously, in
Mm,
research, you need big findings to publish research studies. And if you're looking at very, very subtle changes,
mm,
it usually comes to a conclusion, well, we don't know, and maybe, or no effect noted.
mm.
What about then just small microdosing that's being kind of thrown out there, popular in different hacking circles and things?
Yeah, microdosing is a real tough one, and I, I'm trying to stay open minded about it, but I genuinely don't know what to think about it. So there's only been a few studies that have looked at microdosing, and really, pretty much all of them have shown that it doesn't really seem to have much effect relative to placebo. But there is such a huge mass of other kinds of support for it, other kinds of data, just people saying that it's changed my life and it lifted my depression and it made me more creative and so on. And there really is, and I don't think you can necessarily discount that. I think that's still, that kind of anecdotal data is, it doesn't fit into the kind of clinical trials approach, but I still think it's, valuable. And you have to take that kind of thing into account. Um, the problem is that the microdosing community is so diverse.
Yes.
Um, and people do all kinds of different things and all kinds of different dosing levels and protocols, and people do stacks of things. They call them stacks, where you take, some people are mixing a tiny dose of LSD with a tiny dose of MDMA and some vitamin B and some niacin and some lion's mane mushrooms, and some people are taking that once a week, and some people are taking it every 2 days, and it's really hard to kind of, despite this huge wealth of positive um, positive data about it, if you like, people saying, yeah, it's really helped me. It's really hard to get an overview and actually kind of put all that together because it's just so diverse in the way that people are doing these things.
That makes perfect sense to me. And I like how you are coming at all of these topics with a lot of reason, optimism, skepticism, all at the same time. And as far as kind of open conversations I've had with people, yours has been really one that has looked at things with a fine tooth comb a lot, without making big jumps or conclusions to things. It's like, oh, we've got to figure more out about this, and it's going to be situational too, and we've got to consult with people. I just love that approach and think it's a responsible approach to especially things that could potentially be damaging or really help and get somebody through a difficult time or improve them.
You know what? It's tough to remain objective about these things, actually, because I remember seeing patients doing these trials, particularly the first trial that we did at Imperial, which was in a bunch of depressed patients, and it was treatment-resistant depression patients. So these are patients who were treatment-resistant, meaning they tried several different treatments before and nothing had worked. And most of them had tried lots of different drugs, lots of different kinds of talking therapies. Some had tried even more extreme things like electroconvulsive therapy. Some of these patients had been depressed, badly depressed for 20, 25 years. And I'm not a medical doctor. I'm not a clinical psychologist. I scan people's brains. So I wasn't involved in the clinical side of these trials, but I did scan these people's brains before and after the therapy. So I saw them before and after the therapy. And it made a huge impression on me at the time that I would meet these people first, and some of them looked frankly terrible, which anybody would if they'd been clinically depressed for 25 years.
Yep,
And
absolutely.
I saw them again a week later, and some of them were just transformed. They came back looking like different people. They were open and engaged and just clearly different. And it didn't work for everybody, even in that trial. It worked really well for about a third to a half of the patients. But most of the patients got some benefit from it. But I remember thinking at the time, wow, there's really something to this. And I think most people who are working in this area are enthusiastic and optimistic about it in
Right.
that way, because they've everybody working in this area has got stories like that, which is great. And we need people to keep pushing on this stuff because there's a lot of obstacles in the way, legal and various other things. But at the same time, personally, I feel you've got to try and maintain your objectivity about these things, and you can't get suckered into the feeling that they're a magic pill that will work for everything, because that doesn't exist. So personally, I am optimistic and enthusiastic about these treatments. I think if we can get them out to patients as fast as possible, that would be great. But I also feel like we've still got a lot of work to do to understand exactly how to do that, how they work, what the best ways of using them are, what different disorders they can actually be helpful for, and exactly how to do it.
I love it. Now, we did not get to hormones on the brain or differences in the major sexes. So we will have to have you back. But if somebody wanted to come find you and get more information about what you do, how do they do that?
Oh, sure. I mean, I'm pretty Googleable, I think. Or you can find me on X. I still think of it as Twitter. But I tend to be mostly hanging out on Blue Sky now. So come and find me on Blue Sky as well.
I love it. All right. So definitely reach out to Matt and stay tuned to the next episode of The Hardy Brain, the show that takes athletic, introverted entrepreneurs and leaders and transforms them into ironclad brain performers. Take care.